Good afternoon and welcome to our Orthopedic and Sports Medicine lecture series. I am Dr. Galit Hakim, Assistant Vice President of International Healthcare Partnerships and Insurance Development at Baptist Health. It is my pleasure to welcome all of you to this informative presentation. I would like to extend warm greetings to our friends across Latin America and the Caribbean and everyone joining us today. During this interactive presentation, you'll have the ability to ask questions via the Q&A feature located on the bottom of your screen. I will be your moderator today. This afternoon, I have the pleasure of introducing Dr. Giovanni Paraliticci, who is an orthopedic surgeon and oncologist at Baptist Health. His presentation is titled Lumps and Bumps, What to Do. Dr. Paraliticci is an orthopedic surgical oncologist at Miami Cancer Institute and an orthopedic surgeon at Miami Orthopedics and Sports Medicine Institute, both part of Baptist Health, South Florida. He specializes in the surgical treatment of musculoskeletal tumors, including benign and malignant bone and soft tissue tumors and metastatic lesions. He also manages orthopedic problems in oncological patients, such as fractures, arthritis, avascular necrosis, and osteoporosis. He has extensive training and experience in surgical management of arthritic conditions of the hip and knees, and is skilled in procedures such as primary and revision total knees and hip arthroplasty, partial knee arthroplasty, custom knee replacement, and robotics. Dr. Paraliticci received his medical training at University of Puerto Rico School of Medicine in Rio Piedras, where he also served as a clinical internship in general surgery. He then completed a residency in orthopedic surgery, also at the University of Puerto Rico, followed by a fellowship in musculoskeletal oncology at the University of Miami Miller School of Medicine, and a fellowship in adult hip and knee reconstruction at Miami Orthopedics and Sports Medicine Institute. In addition to his medical training, Dr. Paraliticci holds a bachelor's degree in science and chemistry and biology science of the University of Puerto Rico. Dr. Paraliticci has published extensively in scientific articles and has been a presenter at numerous national and international conferences. He is also a member of the American Association of Hip and Knee Surgeons, the Musculoskeletal Tumor Society, and the American Medical Associations. Please let us give a warm welcome to Dr. Giovanni Paraliticci. Dr. Paraliticci, what a pleasure to see you again. Thank you so much for giving us your time and for joining us this afternoon.
Thank you so much for having me, Dr. Hakim. I appreciate it.
Go ahead and if you can share your screen, we can go ahead and get started. Thank you.
Okay. Good evening, everyone. As I mentioned, my name is Dr. Giovanni Paraliticci. I'm a rare breeding orthopedic surgery. My passion is to do orthopedic oncology, but at the same time, I also do hip and knee replacement and complicated cases of revisions. So I just wanted to talk to you a little bit about what as an orthopedic oncologist that we encounter in our day and how we can help the community to identify these patients that are being treated so they can get the best outcomes for their treatment. So why is knowing about lumps and bumps is so important? So primary tumors of bone and soft tissue, even though this is extremely rare and can be easily missed, it's something that is happening in our society. As the time continues to pass by, the number of cases continue to grow. As the NCI stated in 2014, there's approximately 12,000 soft tissue sarcomas and 3,000 bone sarcomas that are diagnosed annually here in the United States. And of those, 15% occur around the shoulder, which makes it the third most common site. So approximately 11,000 to 12,000 new cases in the United States. The most common, though, even though it's benign, but still malignant happens. And malignant cases, we have to be very aware when they happen. So we should be able to readily identify. The ratio that they occur is 150 to 1. So by 20 malignant soft tissue masses that we identify in the United States, occurring approximately 1 million of those patients here. Most of these masses are painless, they grow very slowly, and they're very prominent in the area that they grow. These tumors are great mimickers of other conditions, such as infections, metastatic cancer, primary malignancy, or benign conditions, such as myositis ossificans that occur when we have any kind of trauma in our muscles. They most commonly occur in the lower extremity compared to the upper extremity in a ratio of 2 to 1, and most of the time occur in the trunk and pelvis in 33% of the time. I want to give you a little definition about basic concepts that we deal on a daily basis. Sarcoma, when we speak about a sarcoma, is a malignant tumor, and it has the potential to grow in an area and then travel to different part of our body, which is called metastatic. So cancer is a common word used for when something grows in an area and then it travels for a different part of our body. This can occur in the muscle, tendons, soft tissues, or any part of our bone. And when we talk about adjuvant treatment, is the treatment that we provide to these tumors in addition to the surgery. And these are given after surgery. And this can be chemoradiation, or this can be chemotherapy, or this could be immunotherapy. And when we speak about neoadjuvant treatment, it's the same thing as chemo or radiation or immunotherapy that happens prior to the patient undergoing surgical management. What is the most important thing that we do when we encounter a patient with an unknown mass or a lump? So we have to do a complete and thorough history with physical examination. I'll tell you that approximately 80 to 90% of the times, this will give us the diagnosis. We got to listen to the patients. We got to examine them. We got to see if they have any other lesions in their body. We got to do a very, very thorough exam and history about when did this happen, how long has this been happening, is there anyone in the family that had the same condition, is there any other factors associated, any social events or in the family that they live that have been predisposed in this, that they smoke, that they don't smoke. So those are little things that we have to be always aware when we're performing our history and physical examination. We combine this with imaging studies such as x-rays, MRI, CAT scan, PET CTs, or ultrasounds. And then sometimes in rare occasion, it happens that a patient comes with a biopsy already performed. So we have some pathological material that we can analyze with our MSK pathologists. Bear in mind that benign or malignant lumps can also be painless. So this should not be one way to discern one versus the other one. Most of the time when they cause pain, they are because they're compressing a neurological structure, or their size is big enough, and it's said that it's usually greater than 10 centimeters. As we were mentioning before, when we're asking to the patient evaluating in the history, how long has this mass been present? Is it painful? Is this associated to any kind of trauma? Did the patient have a prior history of cancer? Or was this related to any other medical condition or syndrome that they have? Are there any other symptoms, like, for example, fever, chills, unintentional weight loss? Or the patient has been taking any kind of medical treatment? Are they changed their diet? All those things factor in at the time of making the diagnosis. In our physical examination, we evaluate the size, the depth, the consistency, and the mobility of the mass. For me, the criteria that are most important, if a mass that is greater than 5 centimeters and is deep and is firm, this is concerning for malignancy. And if something that is more superficial, the study says that 32% of the time, superficial masses are benign. If we have a mass that transilluminate, this goes more with a benign condition, such as a ganglion cyst. If we have someone that had a history of a trauma and has some superficial bruises or ecchymosis, this goes as a traumatic hematoma. If there's something that the mass has a bruit or has some skin changes, such as a hemangioma or a vascular malformation, if you tap the mass and it produces tingle sensation and this pins and needle, this is what is called a Tinel sign. This could be related to a nerve condition or a tumor in the nerve. Another thing important, if there's any enlarged regional lymph nodes, and as we mentioned before, any mass greater than 5 centimeters that is firm and deep is concerned for malignancy. We will try to identify if there's any kind of labs that we can order that can correlate with cancer. But so far, if we order CBC and there's increase in white blood cell count and the set rate and CRP are elevated, this is most likely relevant to an infectious process instead of a neoplastic process. We can have elevation in the calcium, we can have elevation in the phosphorus or uric acid level or alkaline phosphatase. Then those can have some kind of idea that this could be related to a neoplastic process, but they're not specific for any kind of condition. I would say if a patient has a hypercalcemia greater than 10 and an elevation of alkaline phosphatase, then those things are correlated or suggestive of a malignancy. There are different kind of imaging studies that we can order when we encounter a patient with an unknown mass. We can order a simple plain X-ray that is done in the office. We can order an MRI. We can order an ultrasound, a CAT scan, or a PET-CT. X-ray has a limited role in the diagnosis and staging, but this is a very quick and inexpensive tool. And if we have a large tumor, it can show us a soft tissue prominence, and it can help us identify if there's any other features such as calcifications or any soft tissue ossification or mineralization in this area, which can lead us in a differential diagnosis. As we can see in the image in the right, this is a forearm X-ray lateral view, but in the anterior aspect, we can see that there's soft tissue shadow compared to the rest of the area that you can tell there's definitely some kind of mass in that area. Once again, we evaluate the patterns of mineralization with the X-ray. As we see in the image in the upper corner, this is a soft tissue shadow with some kind of calcification in that area. And in the one in the lower, there's some ossification in this area or some kind of mineralization that may be suggestive of some kind of benign or a malignant condition. Here are 3 examples of conditions that I encounter in a very frequent setting. In the one in the left, we have an X-ray of a skeletally immature individual, which has a soft tissue mass in the ulnar aspect that has some calcification or phleboliths in that area. The history of this patient is associated that the mass increases in size with activities, and then when the patient rests, the size of the mass decreases. This is most commonly associated with a benign tumor, such as an hemangioma. Okay, the image in the middle is a lateral X-ray of distal femur that shows a mineral ossification in the posterior aspect of the femur. As we can see, it's a very aggressive pattern of ossification. It's even more denser than if we compare it to the bone. This is more suggestive of a malignant condition that produces bone and is laying down bone. And this is mostly a extraskeletal osteosarcoma. This is a malignant tumor that is a primary bone tumor that it has to be treated with neoadjuvant treatment, surgery, and then with adjuvant treatment. Okay. And the image on the right, it's an image that can happen to anyone that have any kind of trauma. Let's say, for example, this is a weightlifter that was producing, then he had a little tear and he sprained his elbow. So he bled a little bit from the muscle, and this kind produced ossification in this area. And this is what is called myositis ossificans. And this is a benign entity, and this resolved on its own. MRI. MRI has become the gold standard for the diagnosis and evaluation of soft tissue masses. It's very sensitive, and it's easily to localize and characterize a mass in this area. It will tell us the size of the mass, the depth of the mass, if there's any fluid or solid content, is there any other content that is homogeneous or heterogeneous in this area, and if it's invading any other vital structure. We're able to see fat, muscle, and bone. The part that the MRI doesn't help us is for soft tissue calcifications, or if there's any bony involvement or any air in a mass. This will be readily evaluated with other studies. MRI are usually performed with a contrast, which is called gadolinium, which is help us to identify between a solid and a cystic mass. The sequence that we try to identify, and when we discuss these cases with radiologists and MSK radiologists, is we want to see three sequences: the T1 sequence, the T2 sequence, and the fat saturation. If the T1 sequence in the MRI shows a mass that is hypointense, meaning that the amount of the brightness of that mass is very low. And then in the T2 sequence, the intensity of that mass is very bright, then this is concerning for a sarcoma, okay? And if the mass doesn't suppress with the fat saturation technique, this is also a concern that this is also related to a sarcomatous lesion. So gadolinium, as I was mentioning before, help us distinguish in the MRI cystic versus solid mass. Also help us identify if there's any small nodules between the cystic lesions. Is also help us to evaluate the response of the treatment. It helps if their patient has a recurrence of their tumor after the original surgery, or if they had performed a unplanned excision. It helps guide the interventional radiology when they're performing guide needle biopsy, and it helps distinguish granulation tissue versus tumor. So overall, MRI with and without contrast is the gold standard that is ordered when we encounter a mass that we don't know what it is. Depending where you're practicing, I understand that an MRI machine may not be available, or the contrast medium would not be available. Some people in a third world country may utilize ultrasound, or some people in the office may utilize ultrasounds because it's an expensive tool. It can be used as a screening tool to see if there's any cystic or solid component of the mass that is being questioned. And also, depending on the technique, you can identify if there's any flow to this mass. This is unknown. And if there's no flow to this mass, the possibility of malignancy decreases, but still, it's operator dependent, has so many variables that the role of ultrasound in our current practice, I would say that is kind of limited. CT scan back in the days before the MRI era, it was used vastly and throughout the entire world. But now the MRI has really supplanted it and displays the use of the CAT scan. I would say that the CT scan, we use it in patients that they're not able to undergo an MRI because they have a pacemaker, they have a defibrillator that is not MRI compatible. So then in those cases, we have to order a CT scan. The CT scan helps us identify any pattern of mineralization, any lesion that involves the bone, or with the contrast medium, we can identify the vascular structures. PET-CT. PET-CT is a modality that has been ongoing, I would say, for the last 10, 15 years. There's still no specific role for it, but it has been found its way in order to combine the data that this gives us to use it in specific situations. Let's say, for example, the PET-CT evaluates the metabolic activity of these tumors or these unknowns. You can evaluate if there's any soft tissue tumor as in their initial staging to see how much uptake they have from that metabolic component. And then as the patient undergoes a treatment, you can see if that activity has gone down or has stayed the same or has getting worse. Also can say if there's any prior evidence of treatment that the patient, you want to see if there's any recurrence in the area that was treated with radiation or with surgery, then you can also utilize the PET-CT for evaluation. It gives you a specific number, which is called SUV, and that's what the radiologist and us utilize to evaluate it as a response of treatment or recurrence of disease. The management of these lumps and bumps. First of all, we got to identify what is the underlying diagnosis. The lesions can be benign or it can be malignant. If a lesion is benign, we can treat it with a marginal excision. I will go a little bit further and explain it later on. And if it's a malignant lesion, then we should consider what is called a multimodality approach. And most likely, we recommend the patient to go to a tertiary institution that specializes in this kind of musculoskeletal tumors. The key aspect to consider for this management is that the patient should undergo a tissue diagnosis followed by an oncological resection, and we should always avoid a unplanned oncological excision to get the better chances for treatment and response and decrease the complications for the patients. Biopsy. Even though a biopsy seems to be simple, there's a lot of complications that can happen. It can compromise the surgical outcome of this patient if you don't follow some sound principles that are related for the biopsy. That's why, once again, the recommendations from the MSTS is to refer the patient to a tertiary center that specializes in musculoskeletal tumors in order to provide a patient for a limb salvage procedure and can have the access of a specialized musculoskeletal pathologist and complete the necessary imaging for the patient. The MSTS conducted a study in 1996, and I think this is a very good one, that has stated that approximately 20% of those patients that had a biopsy performed at an outside institution that did not have an MSK pathologist, 18 patients underwent unnecessary amputations. So overall, it was 12 times greater than a patient that underwent a biopsy by a trained musculoskeletal surgeon. So there are two types of biopsies that we can perform in the office, which is the fine needle aspiration. And it's a very simple procedure. You can see in the image on the right, it shows that it's a fine needle, no anesthetic is required. It just limits the amount of tissue that you can collect, and it's processed very quickly and is inexpensive. The sensitivity range between 80 to 89%, depending on which case series, and the specificity goes between 72 to 89% too. The one that we use the most is called the core needle biopsy. As you can see in the image in the middle, it's a bigger, large bore hole needle that goes between 1 centimeter to 1.5 centimeter. We have to use local anesthetic, and we do several core samples from this. This will help us increase the accuracy of the diagnosis for this patient. And once again, it is imperative that this core needle biopsy is being interpreted by a skilled and experienced musculoskeletal pathologist to give the most accurate diagnosis. But what happens when the fine needle biopsy or the core needle biopsy don't work, or they don't give us a diagnosis, or they're inconclusive? So that's when we have to go and perform what we call an open biopsy. The open biopsy, there are two types. The incisional one, this is mostly reserved for the patient that we have that there's a tumor that can be, that looks small, less than 3 centimeters, it's superficial, it's not attached to anything. And we just wanted to provide a sample diagnosis for tissue. So we'll perform a directly on top of the mass along to where will be the planned surgical elliptical incision, and we'll just remove a piece of that and send it to the pathologist. Versus the excisional biopsy is that a mass less than 3 centimeters, we perform the resection of this mass with a small cuff of normal tissue surrounding it. And this will provide us with the most accurate diagnosis and decreases the chance of complications as compared to the incisional biopsy. Even though incisional biopsy is performed for small masses, the possibility of performing this in a malignant tumor is still around 30 to 40%. So once we have the diagnosis and we know this is a malignant tumor, we plan for what is called oncological resection. Before we mentioned the intralesional, which was one in the middle, and it's a piecemeal fashion. This is, as we said before, for benign lesions. And we can do also a marginal resection, which is an en bloc excision at the reactive zone, which is the border where the tumor produces a pseudocapsule. As you can see in the image here, surrounding where the tumor is, there's a little gray halo around it. So that's a reactive zone. That's also performed for benign lesions. But in the malignant ones, the oncological resection, that's when we do a wide local excision, which is removing the tumor, but with a normal cuff of tissue. So decreases the chances of local recurrence and complications around this area. And back in the days, they used to perform a more radical procedure, as it says, a radical excision, which was removing the entire compartment. As you guys can see in the image, it's removing basically the entire femur here. Now in the days, because of the advances of limb salvage procedures, we rarely perform that kind of surgery. So this is our goal. We want to avoid unplanned oncological excision. We want to avoid having inadequate images before any procedure. We want to avoid inappropriate interpretation of imaging studies. We wanted to decrease the local recurrence, and we want the best survival for this patient to decrease their re-excision. This is what we have in mind, and this is the reason why we perform tumor boards and discuss these complex cases with a musculoskeletal pathologist, a musculoskeletal radiologist, a surgical oncologist, a medical oncologist, and us as the orthopedic and surgical oncologist team. So every time we're contemplating, we got to think every time we're contemplating to remove a mass, we should consider that that mass is malignant until proven otherwise. We should follow the sound principle for tumor excision to minimize the contamination of this area. And if any time there's any question about a tumor or a unknown that you encounter in surgery, I would say you should send a frozen section for that area, send it to the pathologist, and wait for that. If the pathologist is able to tell you a preliminary and to rule out malignancy, then you can proceed. But if the pathologist is still in doubt, or you don't feel comfortable, or you have your doubts about it, this is a malignancy, you should close and wait for the final pathologist. This is a table that is very, very good. It summarizes what we should do at the time of performing surgery for soft tissue masses. The limb salvage should be the first thing that we try to strike and get for these patients. And if the surgeon doesn't know the incision or the biopsy, this should be sent to a place that deals with this kind of tumors or this kind of unknowns. They should always avoid transverse incision. Okay, this complicates the scenario and decreases the chances of a cure for this patient and success, and increases the comorbidity and morbidity. If there's a need to perform local anesthetic, it should be performed in the same track as the needle in order to avoid less contamination. We should always perform the biopsy in the most direct approach that we can see, so we can avoid developing multiple planes or intermuscular planes, which may produce a contamination for the surrounding tissues or the contamination of the neurovascular structure. So we should always avoid developing any flaps or moving muscles around. We should go straight to where the tumor is. It should be done meticulous hemostasis in order to decrease the chances of local contamination. A tourniquet, if it's thought about using it, you should not exsanguinate the tourniquet. You should leave it for gravity and wait 2 to 3 minutes or a little bit more until then the limb is exsanguinated by gravity, and then you can raise the tourniquet. If a drain is deemed necessary in this area, it should be placed along where the surgical incision is planned for the final resection of this tumor in order to incorporate this track with the final incision of the surgery. Open biopsy should be avoided in certain areas of the body, such as the axilla, popliteal fossa, and carpal tunnel, because it's a very small area and it increases the chances of local contamination, which may lead eventually in an amputation of that limb. And for certain conditions, even though we can use arthroscopic procedures, but we should avoid at the time for diagnosis performing them because there's a possibility of having a malignant tumor. It's in the equation, so we should avoid it to decrease the contamination. So I found this flow charts. I think they're really, really useful at the time that we encounter an unknown. This is for superficial masses. If we encounter, if you think that it's a fluid and it transilluminate in the office, then you can do an ultrasound and you can confirm it. This is solid. This is fluid. If the ultrasound shows that this can be a solid component, then you should order an MRI with and without contrast at that extremity. If it's shown to be more fluid, then you can observe it as clinically indicated. Excuse me. If the mass is less than 3 centimeters, you can observe it unless it's painful. If it's greater than 3 centimeters, you could always observe it or excise it with cuff or normal tissue. If the mass is greater than 3, but it's firm or it's fixed, you should always get an MRI with or without contrast, and subsequently, most of the time, it would follow by a biopsy. If the superficial mass is continued to grow, then this is also a concern that should have further evaluation. But what if we're talking about deep masses, which is the one that we have in the thighs, we can see in other parts of the body. So once again, the same principle, see if it's solid or is it fluid. But I will tell you, at the end of the day, all of them circle back to do an MRI. And depending on what the findings of the MRI, if it's heterogeneous or indeterminate, then you should always follow by a biopsy. Very, very few times it will be homogeneous, unless we're talking about a lipomatous tumor, then it will be more homogeneous. But still, there's a variant of the lipomatous tumor, which may be a liposarcoma, that also would show more indeterminate or heterogeneous, and then that should be followed by a biopsy. And again, no, I would not advise to observe any of this deep lesions, because they can very easily mimic any other conditions, and they can fool any physician thinking that this is a benign thing when is indeed this is a sarcoma. So conclusion, we should follow this proper algorithm at the time that we encounter this soft tissue mass. We should refer these patients to a trained musculoskeletal tumors and a facility that deals with this kind of conditions on a daily basis to give the better chances for the patient and decrease the complications and comorbidity. Benign lesions, even though they're more common than malignant, but still malignant conditions happen and they show up. So we always got to be aware of that. And we should recognize the signs of malignancy, assuming that this is not innocuous. More than 5 centimeters, hard, firm, affixed to the fascia, always follow an MRI and then a biopsy of that lesion. Imaging is essential, and don't hesitate to refer the patient if you encounter this unknown. As I mentioned, any mass greater than 5, firm and deep, it's malignant until proven otherwise. If the diagnosis remains unclear, always should biopsy it. And multidisciplinary care, and I don't get tired of saying it, multidisciplinary team is the key of success to decreases the comorbidities for these patients and increases their chances of survival. So before we end, I want to show you a couple of cases that we've done here at Baptist. This is first one. This is a female with initials FK, 59, with a right thigh mass that started rapidly growing. As you can see in the image in the upper part, it looks homogeneous all around the same area. The part in the left is the skin, muscle, a fat muscle, bone, and all of that in the medial side is the tumor. That was an axillary view, and the other one is more like a sagittal view. As you can see, it goes basically from her groin to the distal aspect of the mid aspect of her thigh. And this is how she looked. She was biopsied to be a spindle cell sarcoma, pleomorphic spindle cell sarcoma. So the protocol for that is to undergo radiation treatment and then followed by surgical radical resection. As you can see in the image in the middle, you see how we mark the extent of our resection. So that tells you, even though this is a huge mass, a large mass, but we have to go broad in order to have a clear margin and to decrease the chances of contamination and local recurrence in this patient. So you can see, look at where the knee is sitting down there in the lithotomy position, and the groin area. That's where we ended up our proximal incision. And this is after the resection of the tumor. So this is the structure that are the vessels, the femoral vessels there, and the remaining of the muscles after the tumor was resected. Unfortunately, we're able to close this wound primarily and did not require the assistance of a muscle flap or a transfer or a free flap from the plastic surgeon. And quickly, this is another case, a patient with initials RG, 51-year-old male, who had a right calf mass that was being growing and getting painful, and he was limiting his ambulation. He was seen at an outside institution, and then once he realized that this is more serious, he came to Miami Cancer Institute. He underwent a biopsy, and it was diagnosed to be a pleomorphic myxofibrosarcoma. As you can see in the upper image, this is an axial view of the right leg. The part of the skin, muscle, bone, and the entire posterior compartment, including the superficial and deep, is invaded by the tumor. This is the sagittal view. You can see the same thing, the skin muscle, and in the posterior aspect, the heterogeneous mass that is in that area, comprising very close to where the neurovascular structures are and engulfing most of the muscle of the calf. So again, you can see the images, how we mark our resection. And sometimes we even redraw the images again about where we're planning to do our resection for this tumor in order to provide the patient with a wide surgical margin. And intra-op, we'll still send some frozen if we have doubt that our margin is, if we're considering this could be some tumor left in this area. So we'll send some samples to the pathologist and they'll tell us, there's tumor, yes, no, okay, proceed. If there's tumor, we got to resect more tissue from that area. And this is an image I told you after the tumor was resected, how the dead space ended up in that area. Then this patient required closure by plastic surgery due to the extent of the resection of this large tumor. So these are the reference. And thank you for your time. I appreciate it.
Wow, Dr. Paraliticci, what an incredible presentation. Thank you so much. I hope we have some students in the conference because I think that they will be the ones to take more advantage of such incredible insight. We have a couple of questions, but I wanted to ask you, Dr. Paraliticci, you know how sometimes physicians from abroad tend to struggle as of, do we refer this to an oncologist or do we refer him to a surgeon that does sarcoma? And simply because of what you described, this solid type tumor, the lack of potential resources, meaning that they probably did an ultrasound instead of an MRI, and they think it is muscular, but at the same time, it looks like a bone issue. How do we go ahead and differentiate as of whom should be the one to see this type of cases?
Yes, that's a very good question. Thank you. So most of the time, we have a combination of the surgical oncologist and the orthopedic oncologist that see this kind of tumors. The surgical oncologist, as my experience from what I've seen here and in our institution, they do extremity sarcomas and most of the parts in the abdomen and retroperitoneum. But the one that goes around the hip, knees, elbows, shoulders, basically the orthopedic oncologist is the one who takes care of them, because if they involve part of the bone or functionality, then the surgical oncologists don't deal with most of the part of the functionality. If we have to reconstruct part of the muscles around the area of the shoulder or the muscles around the knee, so then that's when we come into play. Or if we have, let's say, for example, it's involving the bone and we have to remove part of the bone, so then we have to put a prosthesis, and the surgical oncologist doesn't do that part, but us, the orthopedic oncologists, we do that part of reconstruction.
Mm-hmm. In the case of tumors, for instance, in the synovium that tend to recur, do you guys see them also as first stents and then refer maybe to radio oncology, or how does that work? Can you clarify that?
Yes, very good question too also. So synovial tumors that we see, the most commonly one I see is a benign one known as PVNS, pigmented villonodular synovitis. Patients have recurrent hemarthrosis of their joint. They get recurrent effusions. They're young, they're painful. So they usually are seen by some orthopedic in the community, and then they do an MRI, and then they see a lot of synovitis in that area and a lot of cellularity from the synovium. Some of them have the variant that is localized, so it's only inside the knee. But I've seen the other variant, which is the diffuse one, that it not only it's inside the knee, but it's also around the soft tissues outside the knee. So those are the ones that we see. The ones that are intra-articular or localized, we can treat it with arthroscopic or open synovectomy. I prefer to treat them with open synovectomy because it gives you better chances of eliminating and clearing the synovium from this part of that tumor and decreases the chances of local recurrence. Patients that have failed multiple surgical management from the local one, we send them to the radiation oncologist that they can talk to them about low dose radiation in this area. And also there's a treatment that came out a couple of years ago for immunotherapy that those patients they evaluate the patient as a candidate for this kind of immunotherapy, which also gives good response to them.
That is wonderful, but you still recommend that you can actually
Yes,
see them
yes,
as a
yes.
first glance and then
Yeah.
decipher through the interdisciplinary team what approach to take.
Yeah, we work as a quarterback to see where we gotta put those patients after we treat it and then where they gotta go. So we get them to see the people that they need to see.
Wonderful. We have a question from the DR. At the beginning of your presentation, you mentioned that there are cases, that these are rare cases rather. What incidence of the sarcoma cases you have seen that have been hereditary?
Well, in my practice, they're depending if they have certain mutations. I have seen some of them. Breast cancer, I've seen patients with family that have a strong family tendency in breast cancer. I don't treat the breast cancer, but I treat the metastatic disease from the breast cancer. If they have metastatic disease to their bones, I'm the one treating them. For example, their pelvis, their hips, their humerus, their knees. So I'm the one taking care of them. There's some people that have some hereditary colon cancer. Again, I don't treat the colon cancer, but I do treat them for other conditions. If they develop metastatic disease, again, I see them. There's some other people that have familial lipomatous tumors, so they have multiple lipomas in their body. So they're more prone to develop this tumor. I also seen a couple of patients with multiple hereditary exostosis, meaning that they develop this exostosis throughout their skeletal body. And as soon as they stop growing and this tumor deforms their bone or is causing them pain or that has a fracture, so I'm the one who intervene and take care of them.
I think that you're at a time in the place where I think practicing your particular realm of practice is so important, simply because many years ago, as you mentioned initially, this was a very dramatic result, especially in children that had sarcomas of lower limbs. Now, with the limb salvage approach that you have implemented or that you actually do, with your orthopedic group. How does that compare to, let's say, 5 years or 10 years ago for children in particular, where those diagnoses are severe enough that will require perhaps a complete excision of the tumor and probably not necessarily salvaging it, done now versus now, where you can actually do something to salvage that limb?
Yeah. So there's certain patients that, depending on which time they arrive to our institution, and depending if it's accessible for them or not, the tumor is still in a way that is controllable and it's amenable for a limb salvage procedure. We're able to we treat this patient with the resection of that tumor, and we use a growth spending prosthesis. Okay. There's certain part of the world that for pediatric patients that have this kind of sarcomas, they do another kind of surgery, which is a rotation plasty, which is also shown to give good results. I personally don't practice that one. I don't do that. But I do the one of the expandable prosthesis for this patient. So as they grow, the prosthesis grows with them, and it decreases the amount of revision surgeries that those patients will require until they reach their adult size.
Wow, that is remarkable. Of the 20 malignant cases per million that you mentioned, do you know what percentage are athletes?
Oh, that's a very good question. I wish I had that answer, but I don't know. I don't know the end.
It's gonna make you think now. I wonder how many athletes are large.
I've seen a few though, but I don't know the number.
Yeah, we don't label athletes as a community that must be followed in that sense.
Yeah.
So, yeah. What is the recurrence rate of these type of masses, both benign and malignant?
So that, depending on which type of tumor it is, for example, there's some kind of lipomatous tumors that are more from the spindle cell subtype that even though they're benign tumors, but they recur in a higher rate in between 8-10% as compared as the normal lipoma, that even though you resect it and it's a benign thing, the possibility of that tumor coming back is very, very low. I would say that the more aggressive or the more malignant have a higher chances of recurrence. Depending on the tumor or the sarcoma, we give us one of the two of the examples that I show you. We gave them both preoperative radiation, and the second one we gave preoperative radiation and chemotherapy to increases the chances of survival and decreases the chances of local recurrence from this. There's one thing we can see with our naked eye, which is the gross tumor, but there's always the microscopic part that we're not able to see. And that's why if we can combine this with other medical modalities and it increases the chances of survival of the patient and decreases local recurrence, I think it's a win-win.
Wonderful. Do you see pediatric patients? Are we seeing pediatric patients with these type of tumors in your practice?
We've seen a few of them. We treated it. Since I've been here, I treated like 4 or 5 of them.
So you welcome those cases. I mean,
yes,
if they're identified and they need to come, then we will absorb them as well, and you will work with the pediatric oncologist as well. Wonderful. Look, doctor, I mean, I wish you were my professor back in the days because this made perfect sense. And I mean, it is exciting what you guys are doing, especially for these horrendous type of tumors. We can keep you here for hours, you know that, but we're going to be considerate to you and we're going to say goodbye and thank you. And on behalf of our entire team, you have been phenomenal, and thank you so much for always being there for our patients, especially our international patients. And to all of you participants for attending and for being so always participative. If you have additional questions about today's presentation, please feel free to email them at bhiwebinar@baptisthealth.net. We'll make sure to forward those to Dr. Paraliticci for his response, and we'll send them back to you. We look forward to seeing you at our next Orthopedic and Sports Medicine lecture series scheduled for Wednesday, December 1st, 2021. Thank you once again. Have a great afternoon. Please stay safe and get vaccinated. We'll see you soon. Thank you, Dr. Paraliticci. Have a great afternoon.
Thank you, guys. Have a good one.
Thank you.
Stay safe.
You too.